And the anti-election bill, well, it's not passed with the parliament, sorry. It's waiting in the parliament still. So perhaps the next government will make it a bill. And then there's been partnership with UNDP for the UPPR project. This is the biggest achievement of NDBus, which the UBIS project signed the first contract. Now they are on to the second contract and the third contract as well. Then they are partners with DSK Water Aid and UASA for water and sanitation. They are very much linked with legal services organizations like BLAS, ASK, BELA, others. And they have a savings program and they circulate a regular newsletter. In the savings, we took the federation model, which is there will be savings group, then there will be clusters, right? 25 groups make a cluster, 10 clusters make a federation, and then it's all run by the NDBus Executive Committee. They are now saving with the Mercantile Cooperative Bank. We have started it in 2010, beginning of 2010. Now they have something like 50 lakhs taka of member savings. And there are 2 federations, 20 clusters, 500 groups, and our target was 7,500 households. They have achieved much more than that. The projects that NDBus has undertaken now are UPPR pilot phase successfully completed, as I said, now they are completing the second phase. And they are all over Mirpur and many other areas of the city. Then they have the UNICEF and iWash project, which started in August 12, and they're successfully doing water, environmental sanitation and hygiene promotion services in Ahmad Khan, Muslim Camp, Balu Matsams. These are all done by NDBus members for the slum dwellers. It's like their own work and they're working like a partner NGO. By the way, NDBus got NGO registration, which we started the process in 2010. They have been registered as an NGO this year. And they are a strong member of Coalition of Honorable and other network agencies. Coming to the problem that on the subject matter of today, community health. How can NDBus help? We know that the slums are very areas which have big health problems and hazardous health conditions, especially for children. In our work, we found major problems related to air pollution, poor water sanitation, which has been covered to some extent, respiratory tract infections, skin diseases, helminthiasis, fevers, typhoid, whooping cough, and various eye diseases. Skin and eye diseases are something they need aid all the time, but they have very limited access to qualified and affordable health care. So currently, NGOs provide satellite clinics. I'm talking mostly from my experience in Mirpur and nearby areas, Korai, where they provide free services once a week, and there are private health clinics in the areas, but these are costly and not easily affordable. Well, how can NDBus help? I mean, NDBus as an organization, although urban poor themselves, can be involved in community health. For example, in the UPPR program, they are now building community resource centers. There are already 12 in Mirpur. And Mirpur is the area where NDBus is consistently working, and this area is growing every day. Its members are increasing every day. In every community, they elect normally 4 office bearers who represent the community. Now, these office bearers can also become like, the advocates for health issues, and also to help out in health services. BRAC or any other NGO can establish health clinics in the CRCs. I mean, at least a day clinic or an outdoor something of the sort, and NDBus can facilitate their members to come and get these helps. NGOs like, international NGOs like here have built community resource centers outside Dhaka, especially have seen in Dinajpur, Jessore, Tongi. So we need more of these resource centers, and actually I've been meeting international NGOs who are coming to Bangladesh and thinking about building them in Dhaka and other cities, in other urban centers. So I think we have to help the only way to help is to allow the community to help themselves, and through the resource centers and bringing the service to their doorstep. I think in health, it's very essential that we take the service to their doorstep. Thank you.
Thank you very much, Salma, and also thank you for finishing in time. I think it's very important that you've been able to organize the slum dwellers in such a large number, because as we know that they're constantly on the move, and also to be able to make health available through their services. I would now like to request, I think both of you are going to present it together, right? So both Dr. Nadira Sultana, who is a research coordinator of James P. Grant School of Public Health, and Shoshana Williams, who is an international urban health fellow in the same school. So the floor is yours.
Hello everyone, as Dr. Hamida said, I'm Shoshana Williams. Today I'm going to present to you some of the findings that we've been doing on some of our research. And our study is entitled Mobilising Demand for Primary Health Care Amongst the Urban Poor in Bangladesh, a case study. Our research has been investigating over the last year and a half different case studies where the urban poor have been mobilised to improve the health and well-being in their communities. And today we're going to discuss the case study of UPPR, which actually Salma referred to in her presentation, and discuss some of the key lessons that we've learned around community mobilisation and provision of primary healthcare services in urban slums. So just a little bit of information about UPPR for those who may not know about it. UPPR has been working in Bangladesh since 2009 and is the largest poverty reduction initiative in Bangladesh, working in 23 project towns. It aims to improve the lives and livelihood of 3 million urban poor by 2015, and it looks like it's well on its way to meet those targets, by empowering urban poor communities to identify and then act upon their unmet needs. So this is actually a very similar model of community mobilisation that UDBUS is utilised. So we can see that there's primary groups at the bottom, then community development committees, clusters, and then town federations. I'm just going to briefly describe to you so you understand the model. Sorry. Oh, no. There we go. So, UPPR initially enters urban slums by creating social maps. So they go to communities and they ask them to create maps of their slum. So they create maps that reflect the physical boundaries and the physical infrastructure of the slums, but they also identify the ultra poor and the poor in their communities. And then they mobilise these communities into these hierarchy of community representative-based groups. So initially they form these primary groups. So primary groups are comprised of 20 household members, and then 2 leaders are then elected, and these 2 leaders go on to be part of this community development committees. And approximately 6 to 8 primary group representatives come together to form these CDC committees. Then the representatives from the CDC committees come together to form the clusters, and then representatives from the clusters come together to form town federations, which are also members are comprised of prominent town members such as the mayor and other local prominent leaders. So UPPR primarily enters the settlements by working with these CDC committee members. So they go to CDC committees and ask them to create community action plans. So they ask them to list all their different needs that they have and then what they want to do about them. Financial resources, technical support and facilitation is provided by UPPR, but the idea is for the communities to be responsible for the management and implementation of these projects. So one of the strengths of the UPPR mobilisation structure is its versatility. The structure was utilised by UPPR to engage communities around several different projects, savings and loans groups, and primarily one of the things they wanted to do was develop slum infrastructure within slums. However, the approach was designed to be flexible and responsive to communities' needs. And in some areas where communities started to say, we've got all these health problems and health needs, they started to try and work out strategies to address some of these. And this is where the provision of primary health care services came in. So I'm just going to briefly talk about some of the outcomes that came out of the typical community mobilisation structure when communities were mobilised around slum infrastructure, and then my colleague is going to talk about some of the outcomes from the health initiative. So what were some of the outcomes? When we talked to communities and talked to them about what were some of the outcomes, discussions were highly positive. The women took ownership of the projects and they were really empowered. So they said, whatever we started was successful. And they said, we've built the area's roads, we've bought the bricks, the sand and the cement. And even though they talked about some of the challenges that they faced, overall they were really positive about what they'd done. I'm just going to finish with two quotes. There has been a lot of changes in us. Previously we were hesitant even to walk on the roads. Now we can sit with anyone and talk. We're empowered. We are known in society and we're respected. Another woman said to me, now if we understand if we don't stand together, if we aren't unified, if only one person raises their voice, then nothing will be achieved. If everyone raises their voice together, then it will be strong enough. And I think this beautifully captures what community mobilisation is about. It's not just about some of these tangible outcomes, which are very important, which these projects produce, but also some of these non-tangible outcomes, which will long outlive the project. Now I'm going to pass it to my colleague.
Hi, so I'm not going to waste time. I'm Nadira. I'm her colleague and I'm just going to continue. So, did the mobilization structure used for achieving infrastructural outcomes also work for health? In both Borishal and Tongi, which are two of the sites that we conducted our case studies in, the health project was piloted. But while it was piloted among 12 wards in Tongi, it was piloted on a much smaller scale in Borishal. Much less time was spent in mobilizing and working with communities in Tongi prior to implementation, and while both the sites conducted needs assessment, in Tongi, in Borishal it was conducted in a much more participatory manner. It was done using a lot of participatory tools such as ranking exercises, scoring exercises, effective engagement of stakeholders including local government, local leaders and community representatives was done through the organization of a health fair and a series of workshops, which I'll go into more detail in the later slides, which ensured that proper involvement of all took place, which led to the building of a sense of ownership among community and which sustained the program once project funds finished. So one of the examples of good community mobilization from our case study that we can talk about is the health fair, which was organized with support from the then elected mayor. Here a common platform was created among those who were receiving services and those who were able to provide services or in-kind contribution, who came together and decisions were made then and there at the fair. Community was able to present their need and obtain help and negotiate at the fair. At the fair, when one person stood up to contribute something, this motivated another person to stand up to contribute, and then another, and so on, creating this ripple effect. Another of our findings related to mobilization was about the commitment that was offered by the political and local leaders at both the sites, though to different degrees. In Borishal, this was much more prominent. UPPR helped build linkage between community and political and powerful stakeholders. This then helped build support for and mobilize resources from the formal healthcare system through City Corporation, and ultimately this sustained project activities in Borishal. In Borishal, after the project funds finished, due to huge demand for health services from the pilot project and commitment from these local and political leaders, the project activities continued. City Corporation extended their help by allocating the duty stations of government-employed doctors at UPPR identified need areas. And the then elected mayor extended his help through the provision of money for medicine. And community decided to provide space and helped in the management of clinic activities. This proved to be sufficient for continuing health activities in some of the previously piloted areas in Borishal. So, while the health initiative was successful in increasing access to basic primary health care and equity, one of our observations relates to why the health project failed in other areas. For example, community did not accept the health insurance scheme, which is known as the health card by community, that was designed. And there was some initial confusion about the kinds of services that was provided at the clinic and who provided them. Community failed to accept paramedics or nurses in the role of service providers. We observed that community misconceptualized health. To them, health meant health care and receiving services from a qualified doctor and getting access to medicine. Health is broader than health care and requires attention to the factors which influences health, including the living environment that surrounds them. We found that communities' understanding regarding this was limited. We're still, however, working on understanding ways that communities can be mobilized around health more effectively, and we feel that there is a greater need to understand the literacy of communities for effective program design and implementation. I'd like to leave on this note and thank everyone for giving us this opportunity to share our case study. Thank you.
Thank you both Dr. Nadia Sultana and Shoshana Williams for this presentation. And I would now request Shoshmita Hussain Khan from Eminence.
Good afternoon, everybody, and thank you, Chair, for giving me the opportunity. So I will be one of the very last speakers of today, because this is the last session, and I'm the last speaker of today's session. So both my previous speakers, what they talk about is in community empowerment, mobilization. I would go to the presentation, or I would present a story which is a little different from this, what we all heard. It's about, I would start with 4 interesting slides. Which language is this? How many of you know that which language is this? I thought more of us should know it. I see more Bangladeshi people here. About this? We're talking about community mobilization and engagement. If you don't engage, we cannot do this presentation, right? So how many of you know this language? Right. How many of you can say what language is this? Hindi. Good. Great. How many of you can say what is this language? Very few. It's because we don't have, very good. It's because we don't have a Hebrew channel in here. I would say this is one of the reasons why we know Hindi and we don't know Hebrew or any other languages. It's because the power of visual media. The way we are being exposed to visual media or digital media, whatever you said. That's the reason why a little kid can sit with a really scary looking monster and ask, do you want more tea? That's how community can get engaged. That's the whole idea of the presentation or the project that I'm going to talk to you about. So the project is called Bangladesh Knowledge Management Initiative. We seek for a strengthened health, population and nutrition, strategic BCC and knowledge management initiatives in the country. And for this we have 3 components with the Ministry of Health and Family Welfare, 3 approaches rather. One is capacity building and improved condition. Second is digital resources through e-toolkits and e-learning. And the last is e-health pilot. So I'm going to talk about the e-health pilot, for which Eminence has been fasted from the Bangladesh K for Health, Knowledge for Health initiative of the USAIDs, the Bangladesh Knowledge Management Initiative. This project has been funded by USAID, as you can all see, and Eminence is being the research partner of this e-health pilot. So what gave us the aspiration? One is everyone from my house being able to speak Hindi without even going to a Hindi school, because the digital resources and use of media. We thought that the frontline health workers have a lack of integrated knowledge and skills around all 3 aspects, health, nutrition and population, that we all talk about. Another thing is that the frontline health workers, they lack effective tools. I wouldn't say the tools that they have are not effective, but there are more ways of giving effective messaging or integrated messaging. So we thought, can technology solutions can be used at field level to improve knowledges and skill of field workers and improve the intention to change behaviors in the community. And this is what we did. This is a snapshot of the Health, Nutrition and Population e-toolkit for the field workers. And these three things you see, you go in there and click on that, you will see all the maternal, newborn and child care portions in the health sections in the health portion. Then we have a family planning section and we have a nutrition section in there. It's an offline thing, and you can also see it in the online version as well. You go in there, you click on family planning, you would see all the information on general family planning. I clicked on the family planning methods, of course, that's why it came out. And long-term, short-term family planning method, postpartum family planning, all the information's in here. So one of the questions, I know I'm gonna get it, did we reinvented the wheel? No, we did not. We used all the government-approved PCC materials that the Ministry of Health already uses in all its different projects, and we got an inventory from all the NGOs, government initiatives and other private sector initiatives, and then we did a scoring and we came up with 116 gold standard BCC materials on health, nutrition and population, and we made a digital book like this. Is that all we did? Well, there was something else. We created 8 e-learning courses. We all know what e-learning courses are, and those were small videos, 10 to 15 minute videos, which showed practical way of doing family planning, on maternal health, on nutrition, on integrated messaging, on interpersonal counseling, these things. And you can see here that there are the index, welcome, chapter 1, chapter 2, how do you do it, this kind of thing. And at the end, there was also an evaluation process, questions, like we all do in all e-learning toolkits or e-learning courses. We took it to the field workers who talks with the mothers, who tells them to give your child a zinc when along with the ORS. So these are the things we took it to them. And what did we get is that, what are the interventions? Before going to the result part, I would like to say a little bit about the intervention. So we disseminated the HP and BCC toolkit and 8 e-learning courses among the field workers using netbooks and existing computers. And we looked into the changes in field workers' knowledge, counseling skill, as well as the client's intention to change behavior. Because there is a saying, whenever we talk about e-health, m-health, is are we losing the human face? Are we losing the human touch? So we wanted to talk, we talked with the mothers and asked them what are their intention to change behavior using all this, like information coming out from a device, not from a person. Who participated? 150 HA and 150 FWA, who are the frontline health workers for the Ministry of Health and Family Welfare, participated. They were identified from the district level Ministry of Health and Family Welfare managers, and they received a netbooks loaded with all these digital resources. We went to 12 Upazila health complexes and 42 Smiling Sun Clinic, and all their existing computers were also loaded with all these resources. Of course, we went to Sylhet and Chittagong because these are the low-performing areas, and we had 4 urban areas and 8 rural areas, total 12 sub-districts or upazilas or townships, depending on which park we went. Before going to the intervention or giving the tools, devices to the field workers, we had a hands-on training, 2 days hands-on training, and if you can see, the facilitator actually had to show them how to even hold a mouse. It was much tougher than actually teaching them how to hold a real rat or a mouse. Like running around the room would have been easier. But they made it. After 2 days, they made it. These are the trained field workers in the South Shurma Upazila of Sylhet. They were really happy after the trainings. And then they went to the field. You can see, they showed the clients about the videos, and they had speakers in there for the learning videos in their external speakers. And there are also some group counseling thing that they did. Before going to the results, I would say we did a pre-assessment and a post-assessment. Of course, just we wanted to know what are the improvements that we made. We made some remarkable improvements in some on-the-job training related activities, like what are the appropriate breastfeeding position. We all know 6 months is exclusive breastfeeding time, but what are the positions for giving your child breast milk? We asked them for complementary feeding, what should be the consistency of the food? Should it be liquid or whatever the consistency? So you all can see the blue bar is thankfully higher than the red bar, so makes us very happy. We went to one of the things that we all work in health and health sector in Bangladesh. We know that one of the things, the problem we have is the difference between the health cadre and the family welfare cadre. We don't talk about it, but there is a problem. So we wanted to do an integrated messaging. And after the pilot, we see the family planning methods are being told by the health assistants. So that's the integration. And then you see nutrition by family welfare assistants. So that's what integration. And the reason behind is that they often don't speak about these topics is because they don't know what to talk about. Once they have these things in one device to them, they can all talk about it. Some of the results are why the field worker prefers for digital resources. One of the reasons was it's easy to share information, and then the video attracts the community a lot. Its modern use of information, and community showed greater responses. We have got wonderful, wonderful findings of this study, but I'm not allowed to show you more because we have our dissemination coming in next month. So what are the lessons we have learned? We learned that the field workers quickly learned how to use the netbooks. They were empowered and saw their social status was elevated. The e-toolkit facilitated integration of health, nutrition, and population. The knowledge was improved. The videos were very, very popular. The clients appreciated the netbooks. So what are the challenges? The challenges is carrying the netbook along with their registers they already have to carry. Updating the netbook for us if we want to change, because knowledge changes every day, information changes every day. So updating those things. And the netbooks require ongoing IT support. And scaling up, it needs major investment. But we have opportunities. The Ministry of Health is actually eager to scale this up. They have the MIS, the Management Information System unit of the Ministry of Health, is seeking to place 18,000 netbooks in the community level clinics, where the HS and FWS will go and provide support by the end of this year. And then next year, they are thinking about providing netbooks to the HS by the end of next year. And there are opportunities for scaling up through existing government infrastructure. And we can also institutionalize the e-learning courses as a part of the service training of family welfare. So we all talked about empowerment. We all talked about community mobilization. I don't think I can see a better photograph than this of empowerment. This is a family welfare assistant. She is almost 60. She is about to retire, but she loved it when she got this training, and she was one of our champion field worker. Thank you.
Thank you. I think we need to give a hand to all speakers because they've given us really three different models. One is of organizing the people, particularly slum dwellers, so that they can make demands and see that their demands are realized. And the second one was also under the UPPR project of seeing how women are enabled to participate in their own development. And the third model is slightly different. I think it's how the service providers, how their work can be expanded and enlarged and made much more meaningful. But I think all this is very effective if there is also people have security of housing, if they have the right to shelter, which unfortunately in our urban society, particularly in places like Dhaka city, Khulna, Chittagong and so on, where whether it's due to greed or whatever, the grabbing of land, where the rich and the powerful take whatever they can and the others are driven out. And so while all these images we've seen from the four speakers are very positive, I was also asked to give, so I'll take 2 minutes of your time before we start the question and answer situation. And if you can turn to those slides, where we show what happens to people when their lives are disrupted, either by government agencies or by private property developers, and how they've organized the resistance. That is also an important point to remember. I can just go one after the other. This is what happened in Koroil Basti just last year in 2012, when a bulldozer pulled down everything. Just keep going to the side. That's also the same Basti. These are basically photographs of the Koroil Basti. But you know, we have actually, from I know Shalish Kendra and BLAST and other legal organizations, we've taken up the right to shelter since 1989 when we first did the defense of the Taltula Bosti in Gulshan, which was being demolished at that time. General Irshad was the president of the country. He sent his bulldozers in. And at that time, because both major parties were, of course, we were engaged in the struggle against a military government, both major parties came to support the slum dwellers and fought and resisted and stopped the eviction at that point. Subsequently, of course, it's good to remember that no matter which government has been in power, Awami League, BNP, or caretaker government, slums have been evicted, and Salma knows all about that because she's been part of this exercise of resistance. And so this is what happens. Go to the next. And this woman says that they've only told a day before, a few hours before, that they have to leave. And she left with the child. And where was she to go? They end up in pavements and again look for some other slums. And this is resistance by citizens of Dhaka. But in addition to what other people, other organizations do, slum dwellers themselves have, I think, begun to organize themselves. So they're better informed about what to do when they receive notices of evictions or when they're evicted suddenly. So they come back to legal aid organizations. We take up cases with them on behalf of them, and we have other organizations joining in the process. Not that, you know, obviously the people who are grabbing land are far more powerful and they use whatever is. But we have, in fact, you can't see this, but this is a list of all the cases that have been done, and the judgments from the High Court, the directions given by the High Court, some of which are actually very positive, because the first direction was to give a stay order to stop the eviction. Secondly, I think in the late 1990s or early part of the 2000 year, we have received more positive directions from the High Court, in which they've asked the government not to evict without resettlement plans, not to evict without rehabilitation plans. However, none of these directions have been complied with by government agencies, which means that they're in contempt of court. Thank you very much. I think I would like to now open the floor to discussions. We've had 3 very strong presentations on different models of reaching out and mobilizing the community. So whoever would like to, please introduce yourself and your organization. Yes.
I am Dr. Dewan Mahmoud Hassan. I am working as a senior consultant in Narayanganj Hospital. My question is to Salma Shafi. One question and one comment or suggestion. You have told about healthcare facilities of slum dwellers. And you have also mentioned that hardly they can go to qualified doctors, and it's not, most often it's not affordable to them. Yes, I agree. But you have told about skin diseases predominantly and eye diseases. Why not you are engaged with health education? Because you have told the 2 diseases you have told, these can be easily preventable by taking some measures, you know, health hygiene measures. And suggestion is that sometimes when we arrange international conferences, we call upon different foreign faculties, they volunteers to come over here and to teach us. And in many different parts of the world, there are people who volunteers to be health educators. So you can motivate people. There are a lot of people who want to health educate people. You can, as you are leaders in this field, you can ask them, you can motivate them, and I hope you can do this. And health education, so far health education is concerned, as an ENT surgeon I tell you, many small children, they put many different foreign bodies like in the ear, nose, throat, beans, sometimes they swallow coins. Just if you provide them health education, this is 100% preventable. And often we encounter such problems. So this is a comment and this is a question. Why don't you?
Do you want to answer now? Sure.
Thank you. My presentation was mainly on a project that we did to organize the slum communities. And they have become a registered NGO now, this slum organization, slum representative organization, and they do their own community organization and development activities in partnership with donors and NGOs. Now, the observation on health was what we had found during our work. There are many more diseases, but we found this prevalent. And the idea is that now that the slum communities are doing their own development activities, just like in any other NGO, how they can further assist in health services. And this would be through community centers, the community resource centers that are being built now as an essential part of the development process of poverty alleviation. So I agree with what you say, and I think we're basically saying the same thing, that they need now more at their doorsteps, because when other issues are met with, like food and nutrition and family planning, they need more health assistance every day, and there are more growing children, so they need emergency, urgent attention. They don't need to wait for the satellite clinic or to go to a private clinic. It should be at their doorstep. Thank you.
Thank you. Any other hands? Yeah.
You mentioned something about the rehabilitation plan and slum eviction. I was wondering, what is the present situation? I don't know if I missed it. What is the government doing right now, or if the government or any other party wanted to evict slums at the moment, is the rehabilitation plan in effect, or in what state?
Well, maybe Salma can answer that better, because this is the post-legal. But I would be, for instance, the Koroil Basti, where they had tried to evict the people. We went to court and we got an order to stop the eviction. And this was the Bangladesh Telecommunication Limited Company. They were claiming that land for themselves. And then they did a survey. The court asked them to do a survey, and they found in the survey that the slum dwellers, the residents, weren't actually encroaching on land belonging to anybody else. So they're allowed to stay there for the moment, but you never know, because when governments come, they tend to allocate the land, particularly Koroil land, to different government agencies, and when that happens. But I think to look forward to this, I think we need to look at, particularly urban planners, I think, need to develop plans where you can have the government agencies or whichever property developer developing the land in such a way that the urban residents also have a share of the land. It's been done in places like Mumbai and Bangkok and so on, so it should be done here, and that would be the more progressive thing to do. Yes, please.
As an urban planner present community mobilization from semi-school, I was actually in the plenary session where as slum study shows 10 to 12% women suffer from mental sickness and only 3 or 4% male, contradictory to the two figures. In Bangladesh, on an average, you can say there are about 11% people suffer from mental disease. Last week I saw a shocking news. A student of class 6 committed suicide. And we know the case of Oishi from the affluent society. So maybe the lower community, there is the incidence is lower because the fight for living. Maybe it is higher community people suffer for mental disease. When we can say about the healthcare services or health, we only see the body. We didn't see the mind. For the reason it is, not counted at all. We have established a clinical service department, and we are producing few psychologists. And the psychiatrist is 180 for 16 core people. So, about the community resource mobilization or creating the psychotherapy, psychologist, counselor, para-counselor, we need to think some suggestion. I think so. If the presenter, she is from our semi-school, same thought, and if the chair or anybody can give some light about the mental health, about the drug addiction, about the relationship problem. Please.
So can I add few words to your question? health is a complete well-being of physical, mental and social aspects. Now one thing is coming up with that. That is religion health, spiritual health.
Spiritual.
Possibly we are going away from that point. And
Yeah, it is missing in the definition here also.
yeah, and I think the religion health, there is what is spiritual health. It can add much to alleviate these problems.
Little compliments.
We'll get a response
Okay.
from our speakers.
Yeah.
I think it's a very important issue. I mean, the mental part and counseling. But in the slum communities, things are better, as you just mentioned, from the middle class and the high class, because they are organized, they share everyday activities in groups. For example, last month, my house helper, she comes from a slum, she had her husband thrown out of the house because he was always beating her up. And I think she got some support from me, and then she organized the shalish in the slum, told them that, look, I earn the money and he just eats and doesn't help at all. So they just, so he went back to the village, which is, she's much better off now. So it means that, they get better counseling, they get a better support, which in the other classes we don't. So we see so many sad things in the papers every day. So communities in any social class system, if they help each other, is so much better. And if there are trained people who can do counseling, communities can really help in the mental support. Thank you.
Yes, please.
I have one comment regarding the election. We saw that in the Coral there are a lot of oil of family are living there. They lease the land to the poor peoples and earn more money. Would you comments on regarding the oil of family?
I think like all class systems, even in the slum and squatter settlements, they divide themselves into high, middle and low income groups. And then a high income person is anybody who in a slum has grabbed more land. Also it can be a government staff who makes rooms and rents them out. It's totally just like any developer system. This is the slum developer system. So this is one thing. Then the other is slums are government or private land which people are renting out to each other or to bigger communities. So it just goes in the same system. Eviction, when there's eviction, everybody suffers, but they always go back and then build again. I just have to mention the case of Coral. Coral is something like 97 acres of land owned by 3 government agencies. And the government agencies let their staff build houses to live there, 20, 30 years ago. And each of them grabbed big pieces of land and made a lot of housing. So it is a very vicious system. Even after eviction, they go back and build again because it's a very profitable way of earning a living.
Yes, please. I think we have time for 2 more questions.
So I have a question for the representative from Eminence. So the intervention that Eminence has done is actually to the health workers, right? It's not to the community. So I just wondering, did you also assess the impact of whatever you've done in the community?
Yes, like I was saying, I'm not allowed to say more about the study because the dissemination is next month. Yes, we did interviews with the mothers. We did quantitative interviews with the mothers and qualitative with the community mobilizer groups, what they think about getting information from a device. We did in both baseline and both in baseline and endline, so that we can actually see the intention to change behavior. Because we think that, however, whatever innovative or how much, whatever we give, our pilot was only for 6 months. So after 6 months of giving something to the community, you can only measure intention, and you cannot actually measure any practice. So that's, yes, to answer your question in a short word, is that yes, we did something with the communities as well.
Okay, there was one more hand there. Yes. No, I think we're running out of time, so if you'd like to.
Okay. So because so many slum dwellers are coming from rural areas and are migrating just for temporary work, they view their slums as temporary homes and might not want to invest that much time or money into improving their communities. So how does that become an obstacle? How do you motivate these slum dwellers to kind of feel that they have a tie and ownership to their slums and that they want to improve upon their services and not, so for example, they might choose to pick the cheapest water supply rather than getting a little more effective, a little more costly, because they'd rather save that money to send back to their villages. How do you get them to try to invest in better services to improve their homes?
I think they understand the health issue, but it's mainly tenure which is the big problem. I mean, they do not want to invest money where there is no permanency, because it's very insecure. I think tenure is a very big issue, and this is not the place to discuss it, but it's the root of all problems in Islam. And the last thing I would like to say is, it's the middle class and the high class in any society, in any city, who invites the poor in, because they give them the work. So if Baridhara had low-income housing around it, Baridhara wouldn't have slums around it. So I think we all know, the government just doesn't address the issue, and that's the problem.
I think one way to test it, to see how many NGOs are actually offering services and what is the relationship between the people who live there and the health program that is being offered. And most of the residents in these slums have been there for years and years and years, and they're still using these services. And unfortunately, it gets disrupted only when the slums are evicted and they lose their place of living. I'm told that time is up.
Half a minute.
Yeah, okay.
As we planned Dhaka City, I was the director of Little Airplane, project director, and our honorable presenter Salman was. Actually, I asked for some percentage of land for the poor. When we talk about the health, talk about the development, whether we talk about the equity, the labor come for the better, better remuneration in the city. They give their labor, they build the building. Whether we talk about the equity, if we don't talk about the equity, the words have no meaning. I told that only 4%, our guru of slum development, Richardson, Professor Nazrul, he was in the committee. I demanded, keep 4% land for the urban poor, as 40% of the Dhaka is the urban poor. Say 30%, keep 3% land. No, it did not happen. So who will do it? Government or policymaker or this side, I don't know. If you do not talk about the equity, then this haphazard situation will be prevailing. Sorry, thank you.
Who do you represent?
I don't represent you all.
You represent the government. Also, these type of people are living in the villages. Again, you have created another equity, urban versus rural. And piece of land is very valuable here in the town. And this land also the government land. If all the government's land occupied by the landless, then Dhaka City Corporation or the capital will become a slum.
And so then all land should be given over to all the rich MPs, the rich civil servants, the rich military officers, and that will not make it a rich slum. Anyway, I think we've reached 5 o'clock and I have the last say, so I will not allow you to say anything to contradict me. But I think really we've been presented with a lot of challenging examples of how people should organize themselves, should resist this sort of unnecessary inequality that is being foisted on Bangladesh. And I think I'd congratulate all 4 of you, and thank you very much.
But you have presented something.
Gift din.
Gift later you do. Wonderful.
শেষ কালকে আবার কয়টা থেকে?
কালকে 9:30 আজ দেরি করেন না কিন্তু